All right. I'd like to thank all of our speakers for their talks and ask them to come up to our panel table for our discussion. And I, again, would remind folks in the room to come to the microphones and state your name and affiliation if you have a question. And for the online folks, please do the same in the chat function. So I don't know if Lori's got anyone, not yet. Okay. So I want to pick up on Dr. Malin's presentation, and as I'm sure she is aware, there's currently a challenge to the U.S. Preventive Task Force role in determining payment for a number of medical procedures and tests and whatnot. What could you tell us a little bit about what you think the implications of that suit may have, first for integrative diagnostics and then for medicine in general?
Well, I guess maybe you could provide more context. I'm not aware of a lawsuit, but I will say in general, so with the U.S. Preventive Services Task Force, prior to the Affordable Care Act and kind of codifying that, there was not really a clear path to coverage and, for a number of services. And what they really focus on is services for commercial populations that are covered without having a copay. So it means that it's covered on the preventative benefit. So I think without that structure, I would think that it probably would lead to more challenges in coverage rather than fewer. But I don't know the details of the lawsuit. But I think it's provided a much clearer path, and I think there's a much greater number of services that are provided to people without having to pay a 20% copay on your commercial policy or meet your deductible.
Thanks. Dr. LaPosada, could you maybe provide some insights to us in terms of the trials and tribulations that you went through in building your diagnostic management teams and kind of the practical aspects of how you went about that?
Yeah, it's an interesting story. I was a resident when I had the case which I described. My first job was at Penn. We started interpreting the coagulation test results and gave a patient-specific, expert-driven narrative. And one of the professors in hematology came to my office and said, "You have to stop, you're getting the diagnosis too fast." And I said, "What do you mean?" And he said, "Well, the heme fellows aren't even getting to see the patient by the time you tell them what to do." So I had to stop. That was 1987. And then when I went to the Mass General, 2,000 doctors, 4 people who practiced coagulation. Those people were very outspoken when we started interpreting the test results. And one came in and said, "I don't need this," rolled up the interpretation and threw it at me. And I said, "It's okay, because there are 1,996 others of you who do, so you can ignore it." So it was very well received. The residents at the Mass General for years walked around with a note card that said, "Recommendations, check this, 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 and this." So we tried to build it up beyond that, but for years, people in pathology, in anatomic path, were looking just at the image. It was, what does it look like? And that's my whole job. But we have a liver DMT, which I didn't put up there. But the liver DMT, of course, is hepatitis, hepatoma, liver transplant. It's not just all tumor. And so they've now expanded anatomic-specific DMTs to have tissue base as diagnosis, as the main point, but lots of other diagnostics around it. So getting the anatomic pathology people to say more than just this is what I saw was a barrier. And the clinical pathology people were just running labs. And I just said, that doesn't work. I'm sorry. If you can't give a paragraph on every single one of these cases, then you should work somewhere else. That's what happened.
All right. Looks like I have a question over here on the left.
Yeah. Hi, it's Mary Politi from Washington University, and this is also for Dr. La Posada. I wondered if you had corresponding interpretations of the lab results for patients in their portal, or just for the clinicians relaying that to patients.
Yeah, thank you. That's a very important question. So we learned with COVID how important it was to put it in my chart. So what happened is we can't explain it. We don't have better equipment than everybody. We certainly don't have more doctors. It's a smaller place. So what is it that would differentiate our early deaths and our shorter length of stay? And all we can figure is that we had a personalized interpretation and everybody read it. Now, we could survey them all and see, did they make decisions? But I'll bet that they didn't even think about it. They just said, you know what, I read this, it could be a false negative because somebody wrote this thing and I've been sick, because we looked at information in the chart. And so something happened that was good based upon us looking at all of the PCR, and there were variations on the PCR, the IgM and the IgG. I will tell you now, we added a new test. It's called neutralizing antibody. It takes the live virus of the dominant variant right now, XBB 1.5, and with a lab in a bubble, because it's live virus, we can see if you have antibody to XBB, just in case you're planning on taking a cruise in Viking or you have some illness that impairs your immunity.
Okay, thank you.
Yeah, this was a great session. I'm Dave Dorr from Oregon Health and Science University. And I love the diverse viewpoints and really sort of thinking about this in our very broad systems that we have to get integrated diagnostics into the patients in safe and equitable ways. And I wonder if each of you, with your diverse viewpoints in your areas, can talk about the ways that maybe we can enhance equity, because sometimes innovations are not available to the people who are affected the most, have the most disparity or inequities. Thanks.
Yeah, so thanks for the question. I think for equity, we consider two things, right? One, we design the model that, like for the model earlier, we were told that for the breast cancer, some in the training data, the black female and then the white female, there's unbalanced in data. So how we're able to get the data in the balance so that when we train it include both equally. So that in the training data. Another one we're talking about is that how we were to assess the model equally as well. That is another concept. So for that part, I don't think it have anything to do with computer scientists to make sure that a model deploy equally to everybody. I don't know if any of the panelists here can answer that aspect, but for the training data and design the model to cover that perspective, we're working on it, and I think that's possible to optimize that. Thank you.
You know, I think I would just say kind of thinking about the intended use. So, you know, some of the, I think, earlier talks were coming really at this from a research perspective and including kind of all the different data elements that you would want in a research database. I think if you're thinking about it, you know, kind of how someone would use it, right? You wouldn't want every person to have to go get every test, right? That might be more costly to the system, but it might cost them more individually. And it also, some people may not be able to take the time to do that. They don't get, you know, time off from work to do that, or it might be challenging. So I think to minimize those kinds of disparities, you want to really think about how, you know, what's going to be can you design your model in such a way that you're figuring out really what the incremental predictive value is? You know, are there ways not just of improving the overall accuracy, but when's accuracy not going to be impacted based on, you know, these 5 variables to drop out, you know, this test or something, or to, you know, to add some flexibility. And then also, I think as the question was raised this morning, is everyone going to be going for this, if someone's not a surgical candidate or wouldn't choose certain therapies, how do you also take into account the choices people would make based on, how comprehensive the data has to be on that individual?
I could give you one example that certainly will make you feel good. There's a spinoff from coagulation rounds. We had a case of a child whose father was accused of abusing him. And so we made a diagnosis at rounds that the child had von Willebrand disease. And so the father didn't have to go to jail. And the child was returned home. So that was just the beginning. We've consulted on more than 200 of those. There's absolutely no disparity. In fact, it's serving the lowest socioeconomic class who can barely afford a lawyer. And so we've reunited 44 families, and we've gotten about 10 people out of prison who've been in prison more than 10 years, and one was taken away from death row. And those are the lowest elements of the socioeconomic class.
All right, George, and then Kojo.
So George Weiner from Iowa. So we've been hearing today about how integrated diagnostic is going to be based on algorithms that are probably going to be continually evolving. And I'm wondering what particular challenges from a regulatory and a coverage point of view do you think a diagnostic that continues to evolve almost in real time is going to pose for your decisions?
Yeah, so right now, as I was mentioning in the talk, FDA regulates based on the risk of the device, right? And right now, at least with my understanding, all the AI-based devices have been like the locked algorithm. I mean, at least I'm not aware of anything that has used an adaptive algorithm, but that doesn't mean that FDA won't be able to do it. I'm sure we have the technology to do it. It depends, how this algorithm, how you can monitor the performance of the algorithm after it's been cleared or approved. I'm sure there must be a lot of effort needed upfront, both from the sponsors and also the review staff and FDA, to understand whether a device that was deemed safe and effective, is it going to continue to be safe and effective once it's out in the market, if it's an adaptive algorithm? How do you actually monitor whether the algorithm is adapting to that new information properly and it's still safe and effective? Do you have, so that means a robust pre-market testing performance needed to understand whether the monitoring, whether you can monitor that after it's been approved or cleared, and designing some features to understand that monitoring after it's been approved. So it's doable, but maybe a lot of research needs to be needed to understand how you can monitor this adaptive algorithm performance.
Kojo.
Thanks. Kojo Alanatoba, Johnson Memorial Sloan Kettering. I have exactly the same question, but wanting a response from the coverage standpoint, because the rate limiting step in many cases when we have new technology that's being applied, that's showing benefits more or less in real time, ends up being discouraged by the inability, in simple terms, to pay for it. And I was wondering whether there could be any insights that we could gain from anyone on the panel, specifically Dr. Mellon.
I mean, I think, it is challenging as technology evolves. I think there's more flexibility from a coverage standpoint once you've established a threshold of benefit that warrants coverage. But it does become challenging from the standpoint that, typically most payers will rely on peer-reviewed published evidence. And, and there's examples today, say, for genomic classifiers, like the genomic classifiers say for, predicting thyroid cancer, I think are like 5 generations from what they've published, if not more, right? And so how do you determine that it's really the same thing? I mean, it's very, there probably should be some sort of process to allow technology to get updated. Although I will say from a coverage standpoint, once you kind of get coverage, it typically doesn't get pulled back unless you have evidence of harm. So the real question probably becomes like, how do you generalize it to new populations? And what's your bridge from your kind of original use case or population to saying, we should be able to use this technology in these additional populations, and what's your bridge study to make that case?
So the most, just to follow on that, the most recent example that we have is in the genomics universe. And I'm pretty confident in most people who practice genomics, even in the ivory tower, would probably suggest that what they recover, even with the economy of scale of cost per base, is much less than the test actually costs. So even when we're being paid to do this, the motivation to continue doing this for patient benefit is actually not the best. So think in the context of integrated diagnostics here, that will be getting a lot of inputs from a lot of different modalities, for example, and the contents that actually drives patient care is algorithmic. I think something fundamentally needs to change in the way we see the value that this is created to the patient in a more abbreviated time scale is the point I'm trying to make.
So I think, there the possibility of doing bundled payments. The challenge though then with bundled payments is that internally you have to decide how to divide the pot of money, right? And it becomes an internal political division. And then I would just say also just being very clear about when are you providing value to the patient versus when is there some other value associated with it. Early in my career, I was in the multidisciplinary breast clinic at UCLA. And, it was a very nice vision, but it was honestly not a very good use of faculty time, right? We would sit around, there would be, 6 or 8 of us with, again, actually, that was a good version of integrated diagnostics. We saw the mammogram, we saw the pathology, we all sat around and talked about it, but there were 8 of us typically seeing 6 patients in an afternoon. Not really good value. So, I think kind of thinking through like where are the sum of the parts really better? Where can we be more efficient is going to be really important.
Jochen.
Hi, Joe Leonard's Mass General. One quick comment about this, an approach to answer, I think, the last 3 questions and a comment Dr. LaPosada made, which is about the personalized narrative and how to take AI results and actually bridge them into a clinical decision-making. What happened over the last 2 years, which is not publicized enough, is that for next-gen sequencing, the professional reimbursement code now requires A, to be ordered, and B, to have a patient-specific narrative for coverage. Now think about this. You have probably the most complex test clinically right now, an NGS test. And to get professional reimbursement for its interpretation, you have to have a narrative that's patient-specific. If you extrapolate that to AI, that would patient-specific, meaning to the patient setting. It's not just enough to say, ALK in NSCLC means this, but in this particular patient with this size tumor. Not patient legible, that's separate, that's not a billing requirement. No, like a narrative specific to the patient setting. If you extrapolate that for AI, that could be a way, at least on the end of, when it comes to coverage determination, how to encompass the physician who made the decision, similar to a coag, because the pathologist in a coag setting, in the special coag interpretation, is responsible for that decision, at least by making it. I think that is a very interesting point, also to get to the point of how to cover that in terms of a coverable medical procedure.
Yeah, we've looked at this for a long time, Joe. So it turns out that in the mid-90s, there were 18 Medicare-approved codes. Coagulation happened to be one of them. So when you ordered the test, you ordered the interpretation, which paid professional monies. The tests were done, and the money went to the hospital, of course. And the codes that were now initiated, 80503 up to 7, are ones where we now have on the screen, do you want an interpretation? Because it's not one of the 18. What if your amylase is 1,000, right? So what is that? Is that pancreatic cancer? So you click that box, and it says also that you must say that the patient has approved your requesting this consult. So we made it easy to do the right thing, as was said earlier. Thank you. Easy to do the right thing where they click the box. And our medical executive committee had to approve that. So it's in the hospital minutes that this is okay for the institution. So there are some steps, but I have to say the steps are modest, and people are finding it informative enough that they're willing to press that button and say, I need an expert to tell me what to do. We're showing the benefits financially. We have continued to beat the budget, which they keep putting up higher and higher, for all of the activities on integrative diagnostics.
Charles?
Thanks. I'm sort of hesitant to ask this to Jennifer. It's a bit of a challenge more than a question, but if there's a certain amount of evidence generated early in a diagnostic test, and then you have to make a decision about coverage. As you just said, I think in thyroid cancer, the evidence evolves and no one's really, the use evolves or the test evolves and no one goes back and regenerates the evidence. I guess my kind of question or challenge is, isn't it in your interest as a payer to contribute to the generation of the evidence, in partnership with others? Because if you rely on, efforts like ACR Genie and others to generate data that you can mine for evidence, I've always felt that the payer community ought to be a part of the solution.
Well, I think for PCORI, payers do pay per person to fund PCORI. I think and that's an infrastructure, right, where you have people who are figuring out the best way to spend the dollars to generate research. I would say beyond that, I guess I would throw the question is, how much of your premium that you pay every 2 weeks to your health insurance company would you want to go to research, and would you believe that they're doing the best research with your dollars? I
100%.
Yeah, you would. So then there's no money to go for your medical care. So, but those are the choices, right?
Well,
So what do you is the research, and it's not that there isn't partnerships that happen, but I think if you want more research to come out of the payer community, you have to figure out what's the right infrastructure to ensure that the dollars are going to be spent wisely.
That's fair.
I happen to have a research background, but most of my colleagues have never done research, and are they the folks that you would want making decisions about what research we should be doing?
Maybe to flip it a slightly different way of thinking about it, there must be things that you pay for that aren't necessarily worth it, or the evidence is not super strong, and maybe they should be revisited. And there are others, like, I'll just pick something like, the various Herceptin drug conjugates that are now, I assume you're going to pay a lot of money for Enhertu, over the next 20 years. But as far as, from what I understand, and I'm not, involved in that research, patients are not being discontinued. And someone's going to have to do that work. And I guarantee you, AZ and, they're not going to want to pay for that trial to
Yeah.
shut off their revenue stream.
No, I mean, I agree. I mean, I think there's a real opportunity, especially like with, maintenance therapies. When can they stop? I mean, that seems low-hanging fruit. At various times, I have proposed it to PCORI as places that I think, but no one really seems to, I guess maybe that's a third rail. They don't want to, they're too worried about losing their funding to begin with to do anything that controversial.
All right, thanks.
So, Dr. Phillip, could you give us, what is the best example of an FDA-approved device or technology that is AI-driven, that, the FDA has cleared and is now, in being implemented?
Yeah, there is one de novo, it's a class 2. When we say de novo, that's because there is no precedent. It was in prostate cancer. This is helping the pathologist to get to the right diagnosis. So that was, I'm actually blocking the name of the device, but it's actually, originally it's from MSK, and Page AI is but I'm blocking the name of the device, but it's used for prostate cancer, helping. So all the AI-based diagnostics are helping, in radiology, it's helping the radiologist. In pathology, it's helping the pathologist. So it's not like a new in use, but it's making them do better. And especially this will be for helping the community pathologists. So that was the one that was cleared or de novo last year.
So as a follow-up to that, what did the FDA learn from that process that has now been adapted to sort of move forward in this new environment?
Yeah, so for that particular clearance, like I said, it was a locked algorithm. It's not an adaptive algorithm. So it's actually not so different than how we have regulated the other devices, because you have a device. So someone was saying earlier, it's all depend on what's the training data set. So you make sure your training data set includes the intended population, and you have an adequate amount of training data set. But that's up to the sponsor, whoever is bringing the device. But the validation data set is what we look into, FDA looks into, and that uses the algorithm that was trained with that data set, and it's locked. And then you use, again, the intended use population should be used in the validation data set. But that's where the issue about, you were saying earlier, that in the breast cancer risk algorithm that we found out how if the training data set did not include different ethnicities, that may not work. So that's the part we try to tell the sponsors. Your training algorithm should include all the intended uses, but of course we understand, it's hard to get all the different ethnicities and all that. But then if it's an adaptive algorithm, you don't know whether that's going to work out. So how do you make sure? That's where right now everything is in the locked algorithm. And so if they are changing the algorithm, then they have to come back in with they have to submit a 510K to get that cleared. But in the future, if you are clearing something with an adaptive algorithm, they don't have to come back in, but that bar is higher to get that sort of clearance.
The sage of Richmond.
Rob Wade, VCU Massey. This is directed to Dr. Atai. So I really appreciated your talk about the ethical AI. The question I have is, when is the best application of that? Because it's one, theoretical to talk about it, but is it at the beginning of a project? How is it integrated in a way so that it's either at the beginning or it's while they're creating the project, or do you apply this ethical AI at the end? I get it, but from a practical application, when should the ethical AI start? And I hope I know the answer, but.
Yeah, that's a really interesting question. So when we talk about ethical AI, actually, as I mentioned earlier, it's kind of 6 areas together, right? So right at the beginning of design, we have to take care of that. not all sit together, but beginning accuracy, security, transparency get into picture first, right? And then eventually you're talking about fairness. Fairness comes much later. But when we talk ethical AI, we cover them all, six of them all together in one umbrella. So it's whatever deploy out there, we were testing, like I was also curious about FDA, how they approve and testing to see that the AI model, the deep learning one, I'm talking about deep learning one, not the cellular forestry model, how they're able to verify the model really work out there for the breast cancer. How do they know that it's testing from this hospital to another hospital, correct? Before they approve. I'm curious as well because we, as the computer scientists, we have trouble prove that the model is able to generalize to different data distribution. We're still trying to how to design that and prove that mathematically. So how FDA able to do that? So let me finish my answer to you first, but I'm just, by the way. So I think for applicable, we deploy right now, like for the it's not in I don't know any model deployed in oncology, but for example in the Amazon, there's a model that they do recruit model. They scan in the CV, and then before they really have a human being, HR or project manager read the CV, they have the machine learning screening the CV first and reject majority of them before they move forward. So they use machine learning model to do that. And eventually we will study that model and claim that the model is biased against women. So majority CV get discarded at the first screening stage. It's a female CV, not male CV. However, look deep into it. It's not the machine learning bias against that. But because during the training, the shortcut learning was formed. So somehow in that training model, majority of female have a low GPA and doesn't have much experience, working experience. When the machine learning they train, they found another shortcut. Hey, female reject, not because of low GPA or not long working experience. They just create a different way to, because when we design the machine learning, it's trying to optimize the function, right? As soon as possible. So as soon as they found the correlation, then they just create that bias. So.
All right, and that will have to be our last word. I want to thank our panelists / speakers and for the great questions that we received from our audience. We're now going to break until 4 o'clock when we will reconvene for our last panel of the day.